Good morning. Thank you for having me with you today. My name is Dr. Sarah Galloway. I'm a clinical psychologist at Atrium Health, Levine Cancer Institute in Charlotte, North Carolina. As part of my responsibilities and part of my job, I work in both direct clinical service with patients and their caregivers, loved ones, families, and also work in research, and then also education of our hematologist and oncologist, and then our psycho-oncology postdoctoral fellow. So today, what I'm going to talk about is the impact of anxiety, depression, and social support on cancer-related pain. I do not have any conflicts of interest to disclose to you this morning, and wanted to briefly run through a background or kind of lead you through what I'm going to talk about today. So first, I'll talk a little bit about the prevalence or how widespread is cancer pain. Then also talk about pain as a multidimensional experience. Then also talk to you a little bit about the relationship between anxiety, depression, and pain, and then also social support as a protective factor in a patient's pain experience. And at the end, what I'll try and do is talk about some treatment strategies, the importance of a multidisciplinary approach to pain management, and speak within my specialty, behavioral pain management strategies. So pain is one of the most common symptoms associated with cancer. What we know is about 59% of patients undergoing cancer treatment will experience pain. About 64% of patients with advanced disease will experience pain. And then 33% of patients will experience pain after curative treatment. We also know that pain, there are multiple different components to pain. There's the biological component, so thinking about the actual kind of nociception or the pain itself, thinking about the severity of disease, genetic factors, age, for example. But we also know that our pain experience is much broader and impacted by other factors, like social factors, in terms of economic factors, a work situation, cultural beliefs, social environment, activities of daily living, and then also psychological factors. So our expectations, the different thoughts that are associated with pain, our mood, coping strategies, and also stress. So it is a multi-dimensional experience, not just kind of what we might think about in terms of pain as being the actual kind of sensation of pain. There is a considerable patients with cancer experience a tremendous amount of distress and stress across the cancer journey. We know that there's a significant psychological impact to cancer in terms of shock, denial, loss of dreams and grief, fear, hopelessness, helplessness, perhaps worry about death and dying, a heightened awareness of life's brevity, and search for a meaning in cancer experience. And across their cancer journey, they need to adjust to the symptoms of the disease itself, to the physical impact of treatment, feelings of vulnerability, loss of control, threat to one's identity and self-esteem, significant financial concerns, changes in family structure that might be experienced, changes in functioning. And oftentimes individuals need to grapple with this changes to independence and then dependence that's come from a cancer diagnosis going through treatment, or the physical impacts of treatment or cancer themselves. And so, as you can see, there's a tremendous psychological impact on an individual. We know that about 40% of patients with pain have received a psychiatric diagnosis, and predominantly what we see is changes in worry, or worry and changes in mood that come up. We know that with pain itself, that both pain, anxiety, and depression can layer on top of each other, with not only pain impacting changes in mood or worry, but it also works the other direction, in which we see mood then impacting level of pain that one experiences as well, or worry then will heighten kind of a patient's pain experience too. And I'll talk a little bit more kind of in detail about that, and with some of our own kind of research at Levine Cancer Institute. Also, what I wanted to kind of talk about before diving into specific symptoms of depression is that with folks, individuals that have been diagnosed with cancer, is that they're already at a higher risk than the general population for experiencing anxiety and depression outside of experiencing pain. And what we know is that approximately 42 to 56% of individuals with a cancer diagnosis going through treatment meet criteria for a psychiatric disorder. So most commonly anxiety and depression. And so what you can see is that anxiety and depression outside of pain are very common for individuals with cancer. So what is depression? Okay, commonly what we'll see with depression is we'll see increased tearfulness, social withdrawal. Patients or individuals will complain of no longer enjoying activities or gathering kind of that same sense of joy. They might endorse changes to concentration or attention. They might see that they're using more alcohol or more drugs to be able to block negative thoughts and feelings. They might experience guilt. And a lot of times what my patients talk about also is fear or kind of concerns about being a burden to their family or their loved ones because of changes to their functioning or changes to finances, et cetera, many different reasons. They might also, individuals with depression might also talk about frustration or having difficulty making decisions, that they are also tired or fatigued. They're having difficulty sleeping. They might experience changes in appetite or significant weight loss or gain. When we think about anxiety, individuals will commonly talk about feeling overwhelmed. They have difficulty bringing their thoughts under control and feeling like they're spinning or ruminating with some of their thoughts. They have trouble concentrating. They might also talk about different symptoms in their body. So muscle tension, they might talk about fatigue, so a sense of kind of irritability or restlessness. They might also talk about panic attacks. So these are other symptoms that are more kind of predominantly experienced inside your body. So increased heart rate, shortness of breath, for example, shakiness, sweating, that would be considered symptoms of panic attacks. And individuals might also talk about different nightmares or flashbacks. We also know, kind of shifting a little bit to thinking about social support, is that social support is a very important resource utilized by patients to cope with cancer and treatment. In research of social support, we talk about social support having 3 different components. So an emotional component. So we think about this as expressions of empathy or love, caring, trust. Instrumental support. So this might be tangible aid or service. So having somebody who helps prepare meals, somebody to drive you to medical appointments, for example. And then the last component is more informational. So folks that you might look to for advice or suggestions. And so it's really these three different components that we think about social support. In one of our most recent studies, it's a retrospective analysis, so data that was collected, and then we look back on that data to be able to better understand or answer questions that we might have. We had 7,333 patients involved in our study, and it was a tablet-based distress screening. And individuals took this survey the first time that they came into the Cancer Institute. We had individuals that were stage 1 through 4 with a cancer diagnosis included in the study. And we excluded patients that didn't have or that had a non-cancer pain before coming into the Institute. And what we found, and this was consistent with some of the research available in the literature, is that patients with elevated anxiety also experienced elevated pain intensity. Patients that were endorsing higher levels of depression also endorsed higher levels of pain intensity. And patients that indicated that they had higher levels of social support noted that they experienced lower levels of pain. And when we looked then at patients that were 1 year post-diagnosis, what we found is that social support actually served as a buffer against this relationship between anxiety and depression and pain. So it made that this relationship wasn't as close. So social support really helped individuals. And that this relationship, like I said, was with individuals that were 1 year after diagnosis. And being able to pivot a little bit to then thinking about kind of treatment strategies to be able to help to address cancer-related pain. And also when I talk about some of these strategies also work for being able to address anxiety and depression with our patients too. And the place that we start as a psychologist when we address behavioral pain management is a comprehensive psychological pain assessment with our patients. And what we're able to do then at the end of that appointment is to be able to come up with a targeted and individually tailored plan for our patient. And within kind of a multidisciplinary team, being able to deliver empirically supported, so literature scientifically based treatment for our patients. Also, I wanted to pull up some of the guidelines and the gold standards when treating cancer-related pain from the National Comprehensive Cancer Network. And so what you can see here from this list, and I just wanted to highlight some of these, is that there are multiple different cognitive and then physical modalities outside of medication strategies that can help patients with their pain experiences. So I'm going to dive a little bit into some of these different strategies, but just wanted to show you that there are multiple different science-backed strategies to be able to help patients. First, some of our behavioral treatments that are able to help patients. So what this looks like could be helping patients to be able to pace their activities. So on days that they're feeling really good, we ask patients to be able to back off a little bit of kind of engaging in activities. And then on days that they're not feeling so good, we ask them to increase some of their activation on some of those days. What we're trying to even out through this strategy is that what we find is that sometimes when they're feeling good, patients are feeling good with pain, they'll tend to overdo it on those days. And then they have rebound with the next several days then of not being able to engage in any activities at all. And they might be more bedbound and more sedentary on those days. So with activity pacing, what we're trying to do is even out activity levels for patients, and in the end, make it so that more than likely they accomplish actually more and are better engaged to, or better able to engage in valued activities. We talk about behavioral activation. So being able to identify positive and meaningful activities and then being able to schedule them on days. We also teach patients relaxation strategies, diaphragmatic breathing, progressive muscle relaxation, imagery to be able to help with both pain and then also mood for patients there too, and anxiety. With more acute pain, we'll also teach strategies that are associated with distraction. And then also biofeedback. So this is, we have different ways to be able to measure kind of activation in your body, or different kind of physiologic properties that might be associated with elevated pain. And then teach strategies to be able to decrease some of those the physiologic impact of pain through biofeedback. We also have cognitive behavioral therapy. And so what we find is that thoughts, feelings, emotions, behaviors, and your body are all interwoven with each other. And I'll talk a little bit about this in the next slide as well. But cognitive behavioral therapy is a widely researched treatment, and it's time limited. Sometimes when people think about therapy or psychotherapy, they might think about this as being kind of unlimited and something that they're going to go into and there's no kind of end to it. Really, CBT is intended to be a time-limited, skill-based therapy. What it does is helps to focus on challenging, unhelpful thoughts and patterns that we might have, helps to improve emotion regulation strategies, and help folks to be able to develop personal coping strategies as well. So like I said, what we find is that with cognitive behavioral therapy, your thoughts are interrelated with emotions that you might have. Your emotions are interrelated to what we might do, and then also is related to your physiology and changes in your body. And each one of these is interrelated with each other. And so what this serves, or what this kind of provides for us, is different points at which we might kind of intervene on, right? So we can think about how we might kind of change our thought process. And that can then impact the emotions that we might experience. And that can impact then what we might do. I talked about some of those strategies that can also help in terms of changing physiology. And then learning kind of different strategies or different things to do that might then impact our emotions and our thoughts as well. So there are three different components to cognitive behavioral therapy for chronic pain. One is thinking about, like I said, identifying unhelpful thoughts and increasing balanced thinking. Another one is pacing of activities, like I just talked about. And then the third component I also talked about is increasing engagement in valued strategies or valued activities. I wanted to talk a little bit more about a specific thought process that we tend to target with cognitive behavioral therapy. And that's called, clinically, that's called pain catastrophizing. And really what that is this tendency that we have to magnify kind of a pain, and that we tend to then feel hopeless in the presence of pain. What we're trying to do then is to be able to kind of prevent this, what we, let me see. Sorry, guys. What we try and do is we try and kind of to prevent the pain and inhibit pain-related thoughts in anticipation of the pain coming up during or as we're experiencing the pain and following the painful event. And we tend to become really focused and really attuned to pain in our body and the negative kind of then impact of that pain on our body. And I'm giving some examples of some of these types of pain or thoughts that we have that's associated with pain that we tend to target in cognitive behavioral therapy. So one is, I wonder if something seriously is going to happen when we have a pain, or I'm afraid that this pain is going to get worse, or this is associated with disease progression, for example. I can't seem to get these thoughts about pain out of my mind, or how much it hurts, or kind of what might be happening then kind of in the future. And one of the other things with catastrophizing is we might have kind of a sense of helplessness, right? So I feel like I can't go on, I can't stand it anymore. This feeling of being, or these thoughts of kind of loss of control, that it's terrible and I think it's never going to get better. So these are all the different types of thoughts that we try and then recognize, be attuned to, and then restructure. Pain catastrophizing is significantly associated with the pain experience and with elevated pain. Another strategy that I wanted to dive into too is called acceptance and commitment therapy. It's a form or a different wave of cognitive behavioral therapy, but there's a big difference between cognitive behavioral therapy and then ACT, as we call it. And what ACT tries to do is we're trying to not focus on controlling or fighting the pain, but accepting it. And really what we find is that avoidance also tends to kind of increase some of our suffering with pain. And so we tend to think about mindfulness and to be able to be present with our thoughts, unpleasant emotions or sensations. And there's a significant focus on values and kind of a recognition that pain might get in the way of us being able to do things that then make it so that we have meaning and purpose in our lives. And so really what we're trying to do is really identify those values, and then to be able to figure out how those values or actions that are associated with those values can be present in our life, even with pain being present. And so it's a focus on moving towards kind of valued behaviors. And with that, there's really a big focus on quality of life. And so our goal is to be able to decrease the interference that pain has on our functioning and our quality of life. So in summary, we know that psychological factors influence both the experience of pain and response to pain treatment. There's a significant need to be able to, for providers, to be able to evaluate for psychological and psychiatric symptoms when addressing pain. And on the patient side, what this means is that it's really important to be able to tell your physician when you might experience worry or changes in mood. Sometimes because of stigma or other reasons, we might not be as willing to talk about some of these symptoms, but they're really important to be able to tell your physician. One is because they might be directly related or intertwined with your pain experience. And what we know, though, too, is that this sets up an opportunity in some ways, and that this makes it so because anxiety and depression, and then also changes to social support that folks might experience that are common across the cancer trajectory, these things are modifiable. We can do things about anxiety and depression and changes to social support that can then also impact one's pain experience if the pain itself is something that we can't impact. We can impact the experience of pain, quality of life, and the impact on functioning for individuals. What this also then, kind of some of the conclusions that we then kind of come to with this is that it's really important to be able to address pain from multiple different kind of disciplines. Both pharmaceutical, non-pharmaceutical interventions are essential for pain management. And so I would highly encourage you to be able to ask your physician about supportive care, referrals to clinical psychologists, to other folks who are involved in behavioral pain management strategies. And these can be greatly beneficial for individuals. So at that, what I'll do is go ahead and conclude. Also say thank you again for having me this morning.